start our department's clinical grand rounds. Well, it's on a fascinating topic of how we can find a group of abnormal epileptogenic networks in the brain. And the challenge is, what do you do if the MRI is completely normal? And obviously, you do an MRI, you find a lesion, you can do surgery. You could have some other investigations which could correlate this lesion. But what do you do if the MRI is completely negative? So, of course, a word of acknowledgement for all the residents for having turned up. And I would also like to thank Roop Narayan, who is there. I think he's the reason that many of the residents have turned up here. Okay. So stereo electroencephalography is not a new technique. It's been practiced since a very long time, since 1970s. In fact, from this hospital, Saint Anne, that is where it was developed by two neurologists, Talleyrand and John Buncord. But at that time, the way they used to practice SCG was very different, because most of the investigations that are not available today were not available at that point of time, which are available today. For instance, they did not have a very good quality PET, or they did not have a SysCom or a SysCos. So the pre-operative localization was quite limited. And that's where they said, let's put in some very fine electrodes in the brain and we can localize it. And they produced some excellent results. But for a very long time, if you can see, it was limited only to some small areas of France and some other areas within Europe. And only since 2024, 25, it started exploding. And many centers around the world started doing this technique. Now, there are two ways, in epilepsy surgery, normally when you do not find a lesion or you have some confusion about lesion or there are multiple lesions, you need some additional mapping. So one way is you could put grids, close up the patient and then do monitoring till you get some ictal spikes. Now the problem of putting grids is that whenever you need to remove grid, again you have to do a craniotomy and take it out. So obviously the morbidity and the complication rate for grids are higher. The advantage of SCG is that they could be explanted within the ICU. So the infection rates are practically nil. So can I have a raise of hands among residents who have seen SCG? Can you raise a hand? So many of you have seen this procedure. The other advantage, of course, is that it provides a three-dimensional mapping about the brain. So you're putting electrodes from, so you're getting a three-dimensional. Even when we map language areas, when we see the typical Broca's area, we feel that it's something like a paper it's a two-dimensional on the surface of the brain. It's not so. So when you map it, you can see that there is a three-dimensional area which grows inside. So obviously over a period of time, if you look at it, now one of the main problems for SCG was the issues of language mapping, because if you have a grid on the language area, you can cover the entire language area. But if you put some electrodes into the language area which are going inside, the idea is, will you be able to cover the entire language area? And surprisingly, we are able to do so. So even though if you put some limited electrodes, you are getting an excellent coverage of language. So that shortcoming has been bypassed. But the best part is that these electrodes are very thin, 0.8 millimeters, and they can be very safely implanted, very minimally invasive, hardly any risk of bleeding, no risk of infections. So far, we have not seen as compared to grid placements. So safety-wise, lower rates of infection, faster procedure, lower hospital stay. It's got versatility. You can do bilateral mapping. So if you have grids, you can't put on bilateral hemispheres. It's very useful for insular epilepsy. If you remember the anatomy of insula, it goes inside the depth. So you cannot put grids on insula. But the way you can map it is you can put electrodes which goes through and through. And obviously it has a higher rate of control than STA. So we were the first institute in this country where we have started implanting and using a very formal and a very precise and a very standardized SCG program. And currently ours is the only major center which is doing SCG for all the complex epilepsy cases. So I will ask Dr. Aparajita to come and speak about indications.
Good evening, everyone. So before I discuss the application and indications of stereo EEG, we'll discuss something about the principle of stereo EEG. So it sir told, it was described first by Talleyrand and Boucard in 1965. And they gave a model of epilepsy in which the epileptogenic lesions were divided into 3 regions. So first was the lesional zone, surrounding it is the irritative zone, and third is the epileptogenic zone, wherein the ictal discharges, they primarily organize and then spread to the rest of the brain. And it is imperative that this zone is removed so as to achieve a sustained seizure freedom. So this is a management algorithm for pre-surgical evaluation for drug refractory epilepsy, which is defined as the failure to attain sustained seizure freedom despite appropriately chosen 2 anti-epileptic drug in optimal dosage. So I know it looks like a busy slide, but this is how extensive the pre-surgical evaluation for a patient with drug-resistant epilepsy is. And despite this, around 1/3 of the patient with MRI negative, they are not able to reach a final result. So despite phase 1 investigation, when we are not able to reach a concordance between the clinical, electrical, and the anatomical substrate, we go ahead with the phase 2 investigation. So before going through the phase 2 investigation, we have to first ask whether we have a reasonable hypothesis to go ahead with. If there is any technical limitation of the existing investigation that has precluded us for reaching that conclusion, are there any other non-invasive techniques that are left, like SPECT, PET, or MEG? Whether this stereo EEG that we are planning for the patient is going to change our endpoint in surgical management, and if we can achieve that same result with an intraoperative ECOG, and if the family and the patient is going to cooperate with the further decision. So the primary goal of stereo EEG is to define the epileptogenic network. And second is to determine the location of eloquent cortex in relation to it. So stereo EEG is not a fishing expedition. Stereo EEG, it complements the non-invasive evaluation. So before going ahead, we need to have a proper hypothesis. And based on this, we plan an adequate number of electrodes to test our hypothesis and to go ahead further. So primarily, the indications can be divided into 4 major categories. First is to define the epileptogenic network when the non-invasive data is not conclusive, especially in patients who are MRI negative. Second is to resolve the differences of non-invasive data when it is pointing towards 2 or more regions, especially in patients who have multiple lesions, who have bilateral lesions, and in conditions like tuberous sclerosis or heterotopia, we encounter such difficulties. Third is to map the eloquent cortical function like motor region, language areas, or sensory region. And then we have certain newer indications which we have also explored. That is to do radio frequency thermocoagulation of these of the potential zone, so as to test our hypothesis to confirm it, and especially in certain difficult lesions which are not amenable to resection, it can also serve as a therapeutic procedure. So in 2018, Esnard and et al. Also gave their guidelines on stereo EEG, emphasizing its role when the non-invasive data is inconclusive for optimizing the surgical planning and to explore deep or difficult to access regions. This score was developed at MNI Canada based on the extent of lesion, the extent of ictal EEG and interictal EEG, localization semiology, and deficits on neuropsychological assessment of patient, to decide whether the final result of the stereo EEG is going to be focal or non-focal, and based on which the resective surgery is feasible or not. So despite the so many advantages that we just now saw, there are certain technical limitations to stereo EEG. Because it is going to sample only a limited volume of the brain, our placement of the electrode has to be very precise. Secondly, it may be difficult to map the entire extent of the eloquent cortex. And in certain situations, like children with skull thickness that is less than 2 mm or large unilateral lesion which require extensive mapping, it might not be so ideal. Next, I call upon Dr. Aishwarya to describe the surgical techniques.
Good evening, everyone. There are 4 steps in SEG placement. So this is step 1, recording of the spontaneous seizure. So minimum 3 events have to be recorded after tapering the anti-seizure medications. So this is stimulation following the spontaneous seizure recording. So there are two types of stimulation. One is low frequency stimulation and the other is high frequency stimulation. And high frequency stimulation has to be avoided in eloquent cortex regions and in the region of the hippocampus and also in regions where those have a high seizure potential. Yeah. So this is step 3, that is radiofrequency thermocoagulation. So here, after finding the onsets are ablated at 75 degrees Celsius for 60 seconds. The step 4 is resection if required later. So if the patient is seizure free, then no further treatment is required. But if there is recurrence of seizures, then with the SEG hypothesis, patient is planned for surgery. So this is an example of a patient who had a left temporal hypothesis. So this reflects the utility of SEG because in this patient, the hippocampus was spared. And the histopathology was type 1 focal cortical dysplasia, and patient has been seizure free. So this is a surgical technique. So first, the patient is placed in supine position, and this is followed by head fixation to a Lexell G frame. So we always follow a 6-point laser skin fixation. Now the robotic arm is driven to the desired trajectory. We have times. So this is a twist drill, 2.1 twist drill craniostomy. And this is done using a handheld pneumatic drill. So that is a stopper, and this distance has to be calculated. That is a scalp and the bone thickness in order to avoid inadvertent injury to the brain parenchyma. So the surgeon can appreciate the initial resistance of the outer cortex. Then there is a sudden giveaway feel. That is because we enter the diploic space. And again, there is a resistance when we enter the inner cortical margin. And then the epidural space is entered. So then the dura is coagulated with a monopolar cautery. So this is the anchor bolt. So the anchor bolt is inserted now until we get a good bony purchase. So this is followed by calculation of the distance. There are two things here. One is distance to the target. So that is from the robotic arm to the target point. The other is distance B, that is distance from top of the adapter to the top of the anchor bolt. So this length has to be calculated separately. And this will be measured using a measuring scale intraoperatively. And the distance of the length of the stylet will be the distance of the arm to the bolt. So it is ensured that the adapter is removed before moving the arm to the home place. Now the length of the electrode is calculated, that is A minus B minus 3 mm. This 3 mm is because the cap is rotated and tightened 3 times. So there are various commercially available electrodes. And this is a final insertion of the electrode through the anchor bolt. And you can see that initially it is tightened. And this is followed by removal of the stellate. Followed by final tightening of the cap over the anchor bolt. Yes, sir. So these are the various studies, and our study is the first publication from India. And the advantages of our study is that we had a large cohort of MRI negative patients with the least number of electrodes. That is on an average 8 to 9 electrodes. And this helped in optimizing resources with excellent results. Now I would like to call upon Professor Manjari Tripathi to discuss about illustrative cases.
This is not the Mac, huh? This is the computer here. Okay, I hope it works. So we'll just give 2 illustrative cases. This is for the residents. One is a patient who has, treatment with the coagulation, and the other one had coagulation, and following which there was an asymptomatic period and again recurrence of seizures. So someone of you must have worked up this patient. He's, having epilepsy for 22 years, and age of onset was at 14 years. And he would have one episode every 15 to 20 days. The maximum asymptomatic period in his life was for 3 months. And when he came to us for evaluation, his seizure frequency was once in every 10 days. They were both occurring in the night as well as in wake, and many nocturnal seizures may actually have been missed. And the events used to last for 1 to 2 minutes, and there used to be occasional incontinence. Now, the patient himself said he used to have an aura, and the aura used to consist of forced thoughts of which he had no control. So he would be, suppose he is, playing with his friends, and suddenly there would be recurrent forced thoughts in his head, like go shut the computer, go shut the computer, go shut the computer, go shut the computer. He is nowhere near a computer, but he's playing in the field with his friends, but his mind is throwing thoughts at him to go and shut some computer. So there used to be thoughts like take the scissor and cut everything up, take the scissor, cut everything up. So there were these forced thoughts which were coming into his head, and these used to be followed by confusion. And it used to be followed with staring episode for 20 seconds. And sometimes they had noted right upper and lower limb movements, and sometimes the parents had noted both lower limb movements. So if you look at the semiology of forced thoughts, as well as this lower limb movements and nocturnal and morning occurrence, you would think it is a frontal lobe seizure, because the episodes were again very, very brief. There was another type of episode where he would become confused and he would forget what he's doing, and that used to last for a little longer. So he had 2 types of episodes. The first one was with forced thoughts, very brief, 10 to 20 seconds. Second was a little longer with confusion and amnesia. So when you look at this episode with confusion and amnesia, you'll think it's probably temporal in origin. Now, he had no memory component to the forced thinking. It's not like if he gets a thought of holding a scissor and cutting everything up, he would actually feel angry and want to cut up things. So there was no emotion attached to these forced thoughts. And that is what made us think that it is probably a frontal lobe origin, and there is some temporal lobe component. So the networks for frontotemporal. And then we looked up the literature, because this was the only case we have in our series where there is a forced thinking. And we read up the literature where forced thinking arises from left frontal lesions, mainly the mesial frontal, but can also be the dorsolateral frontal. Some people have also called these kind of seizures as hypercognitive seizures, which is a phenomenon of forced thinking as an aura in epilepsy. His interictal EEG, which was done, didn't show much, except maybe you can say there is some kind of a reversal at T4. So we were not very sure, but this is his semiology. So he's fidgeting with his mobile, and then he puts his hand at the back and moves his right lower limb, only right lower limb. He's unresponsive at this time. He's not responding to the staff's commands. Kitni ungli hai? Naam kya hai? And both his hands are kind of fixed. There is no dystonia seen. He does not obey commands.
क्या है? साथ में कौन है आपके? साथ में कौन है? नाम बोलो अपना. अपना नाम बोलो. नाम बोलो अपना.
So he's still confused, not telling his name.
कहाँ हो भी आप? कौन सी जगह है?
Now he says AIIMS mein hu main. Okay, so this is his ictal EEG onsets. As you can see here, there's nothing much seen in this epoch, but as we move, we find a rhythmic, sharpish activity starting from right frontal FP2. So this is sharp starting at FP2, and also then later on goes towards the temporal T4. So we see it evolving. It starts at FP2, goes to T4, and then evolves in FP2 as well as T4. You can see the spiking component. So our clinical hypothesis was correct. It was a frontotemporal network. The onset epoch is FP2. Maybe somebody may say there's some fast activity here also. But evolution is both FP2 and T4. And it tends to evolve with better phase reversals at T4. So based on the semiology, we said again frontotemporal networks are involved and imaging was done. Now this patient was discussed 5 times in the epilepsy surgery meeting, which is held on Mondays with the radiologist. And the only finding the radiologist said was there was no hippocampal atrophy. But the volume of the temporal horn was a little wider on the right. So the volume of the temporal horn is wider on the right. There is no true atrophy. You don't see any true atrophy. So that was the only finding, query dilated temporal horn. Now, of course, if we find this finding, we will go ahead with, I don't think I have time to show all the detailed imaging. The arterial spin imaging, labeling ASL, which is a perfusion study. Only in the basitemporal cuts, it showed a hypoperfusion relatively larger of the right temporal lobe. The ictal SPECT, which was done within 20 seconds of his ictal onset, shows bifrontal, basifrontal uptake in the syscom. So this is subtraction ictal SPECT. Ictal minus the interictal gives hotspots in the basifrontal region bilaterally. The PET, the first read of the PET, this is the PET CT. Okay. So the first read of the PET, they said PET is normal. Okay. But when you fuse the PET with the MRI, which is PET MRI fusion, they said the right anterior, nuclear medicine and neuroimaging, right anterior temporal pole is a little more hypometabolic. The magnetoencephalogram showed strong dipole in the right basimesial temporal. So this is, in MEG, right is right. Unlike the MRI, where right is here, in the MEG, the right is right. So there was investigations which showed us a clinical hypothesis was frontal. And of course, we didn't know which frontal, but forced thoughts in literature are lateralized to left frontal. However, all our hypotheses, including the video EEG onsets, as well as the PET, were right temporal. Video EEG onset was also right frontal. So our hypothesis was that it is involving the frontotemporal network. And we tended to have localization more to the right than the left. And we thought we will go ahead with the SEG implantation to localize further and prove our hypothesis. So with this, an SEG implantation was done after discussing in the epilepsy surgery meeting.
So good evening, everyone. So this is a team effort, basically, both in the operation theater as well as here. So as we discussed, Madam elaborated on the case. We had some doubts that because of the semiology and video EEG was localizing to the left side, I mean left or the frontal, not left exactly. And rest of the investigations were localizing to the right-sided temporal, including the MRI. So we were not very confident enough to go ahead directly with the surgery. So that's the reason we chose to implant the patient. So in this patient, because mostly our hypothesis was on the right side, so we placed a complete right temporal exploration because it was a temporal lobe kind of epilepsy, because the seizures also were pointing towards temporal lobe because of the prolongation of the seizure, and it was like a temporal semiology as well. So based on that, we placed right-sided electrodes in the standard temporal exploration involves hippocampus, both the head and the tail, amygdala. And also when you pass the electrode, it goes from the cortex to the deeper side. So it will take into account the anterior temporal lobe, that is, you can choose to put into the superior temporal, middle temporal, and inferior temporal. That actually is a standard which the West practices. But at our setting, we have optimized this strategy so that we place lesser electrodes and then try to gain more. That's basically because we do maximize the preoperative investigation so much that we are sure enough that this could be the thing. That's the reason we are placed into insula. We covered here because as a part of the network of the temporal this thing, and right mesial frontal because of the semiology which was pointing towards force thoughts which was pointing towards extratemporal, that is frontal. So these were the electrodes we put. Electrodes come in different varieties, like they range from 8 contacts to 18 contacts, which is the maximum. So we use for insula and the longer trajectories, we use the maximum number of contacts, and the smaller ones we use the 8 contacts. So this is what is our schema. So this is a software, a 3D software called Gadel, which we have recently been doing. And this, sorry, doesn't play. So it gives you a 3D orientation of all these electrodes, which from the lateral to the inner contacts, which is a very good tool. And then you can visualize, because many a times it is difficult to see on a 2D imaging that how the electrode is going. And most of the times, Professor Manjari sometimes gets annoyed that you show me where it is exactly. So this is how we can show her, because it's like a 3D, it's right, 3-dimensional view, and then you can actually show it going into the depth. So we implanted this, and then I'll call back Dr. Manjari to explain.
So he had similar seizures. In fact, they were a little more expressive than his first phase 1 seizures. So you can see the event starts with movement of both his lower limbs. There seems to be some dystonic posturing of the right foot, but then he has these movements, tapping movements of both his feet, which look like bipedal automatisms. But here he is responding. He shows his tongue, but continues to move his legs. So he is responding fully, but moving his legs in automatic manner. It is not clonic. Clonic will be like this. This is automatisms, and that is his seizure. And he had several of these during the phase 2. So you can see beautiful ictal onsets, which is seen with low voltage, high frequency activity. And it starts actually in these green electrodes, then moves up and down, and then moves further down. And I'll show you the electrodes, and then moves to these green electrodes. And then it progresses like this. So if we minus electrodes which didn't show the activity, you can see here that the ictal onsets are right hippocampal 1 electrode to 6, followed very quickly by right anterior temporal 1 to 3, followed very quickly by RPT 1 to 4, followed by RIA, right anterior insula, which is 17 and 18, and then it goes to the left side. So that's why probably you were getting even left frontal in the syscom. So it starts like that and propagates like that in the stereo EEG. And when you expand it, the similar thing is seen here. The fast activity starts in these electrodes and propagates. Again, another event which looks very similar, showing the same onsets in the same area. So let's see what these areas are. So the spontaneous seizures were mostly from around these areas. And then there's stimulation. So this is stimulation where you stimulate. And after stimulation, he has the seizure again coming from these areas again. Okay. So post-stimulation, he has similar episodes. And we documented that also. And stimulation of the hippocampus also produces similar episodes. I don't have time to show everything. So basically, the spontaneous seizures, we recorded several, were coming from this area. The red ones are the ones from which RPT here, though we call it posterior temporal electrode because its entry point is posterior temporal. The onset is here. And subsequently, this is seizure 2, again the same areas. So we chalk out, the epilepsy surgery fellow chalks out the areas which are it's coming from. Then spontaneous seizure 3, again same area. So we validate by documenting many spontaneous seizures. Then stimulation also produces seizures from similar areas. So this is just the stimulation positive seizures. Hence with this, we had developed a hypothesis. The basifrontal actually didn't show anything. Left hippocampus also didn't show anything. And with this, we counsel the patient for a ablation. So ablation part will again be discussed by Dr. Ramesh, how we counsel for ablation and what we do.
So with this, you could see that the seizure propagation, actually by putting SEG, we are actually mapping the networks. So you saw that it started from the right anterior temporal, that is a hippocampal head, and then it was picked up by the electrode which we have placed in the tail. So it is basically proving our hypothesis that the propagation is from the anterior to the posterior through the hippocampus. So that gave us a better idea and a concept of the epileptogenesis. So that's the reason we could actually localize it to the right side rather than the frontal, which was based on our semiology and video AG. So with this, we went ahead with the culprit electrodes ablation. Basically, what we do is, as madam showed, initially we do the spontaneous seizure activity and then we confirm it again by stimulating the electrodes. We produce the habitual seizures. And then finally, once we are sure, we go ahead with the ablation because these electrodes are implanted in the OR under GA, general anesthesia, but they can be removed at the bedside. So that is a major difference of using a subdural electrode versus a SEG. So that is why SEG has become more popular, that stereoelectroencephalography has become more popular. Because putting subdural grid and then placing the patient in the OR, we'll have to remove it again by taking back into the operation theatre and then remove it. But here, it is done bedside. So we counsel the patient before the ablation of these electrodes. Like the main complication which can happen while after ablation and while removing is the bleeding. Hematoma can occur because sometimes vessels will be there in the vicinity. So we see the plan on the ROSA platform, that's a robotic platform, to look for any vessels in the vicinity so that we try to avoid that particular contact. If it is there, some vessel is in the vicinity, then probably the risk of hematoma increases. That's the reason we don't ablate those regions. So that is one thing. And then we counsel the patient as well before. And yeah, so that already Aishwarya showed that what happens is, like at the bedside, we have a junction box which is connected, which has all the abilities like from recording, then stimulation, and then ablation. So all these three, there is a switch which can be modulated so that you first record it, then you do the ablation, and then again re-record it, whether to see that firing is stopped. So that is another point. And then we proceed with the ablation. Ablation we do at 75 degrees for 60 seconds. And when we do it, our fellows most of the times put a stethoscope and then also ask the patient. Many times the patient himself tells that there is some popcorn like sound happening inside his cranium because of the coagulation of the proteins which happens. And then it is also very much audible when you put a stent on it. So that indicates that the tissue has been cooked well. I mean, because when we use and the popcorn sound comes, that it is burnt well. So that is what it indicates. And in this patient, we did the ablation and then he is seizure free. So this is the video of him.
कोई एक बार भी सीजर्स नहीं आए हैं, अभी तक सीजर फ्री है।
एक साल हो गया?
जी नवंबर में हुआ था SEG और अभी तक सितंबर है तो अभी तक
So he's finished more than a year now. This thing was done. So he's seizure free with just ablation. Okay. So the second illustrative case is one who required surgery even after ablation. She's 18-year-old. She's a young girl and right-handed and funded by PMJ. Age of onset of seizures is 9 years. Duration is 8 years and 1 to 2 per month. Maximum asymptomatic period is 7 months. She was on 3 drugs, as you can see. The home video of the patient was bought by the family members. We always see the home video to generate the hypothesis. And you can see here that the head is turned to the right, her left hand is flexed, and she has generalized very fast. The mother used to say that these episodes would always cause her head turn to the right. And she would keep looking to the right and she would become unconscious immediately as the seizure started. But when you ask the patient, she says that there was some ghabrahat before becoming unconscious. Okay. So obviously there is an aura of ghabrahat followed by a head turn to the right. So hypothesis lateralization even on home video was left side, and since there was ghabrahat, it was amygdala or the hippocampus, which is involved, more likely the hippocampus based on the home video. As you can see here, the interictal EEG shows kind of sharpish phase reversals, but they are kind of seen bilaterally. And centrally also you are finding these phase reversals which are coming. Okay. Then this is a habitual seizure which is captured in the epilepsy monitoring unit. Very rapidly her head turns to the right, her right hand flexes and it is very much like the seizure which is in the mobile phone video, home video. She's generalized very fast. She did not even complain of the aura. She just turned her head to the right. And then she has generalized. So keep observing the seizure. So last clonic jerk is left upper limb. So last clonic jerk is always ipsilateral. So ictal onsets were very broad, as you can see here, almost bilateral. You can see bilateral simultaneous polyspikes looking almost like a generalized onset. But if you look very carefully, the morphology as well as the distribution is better defined on the left as compared to the right. The right is a little more restricted in terms of its duration at its onset as well as its spreading. The polyspiky character is much more seen on the left. But you can't swear and say it looks almost bilateral onsets, and it's kind of reversing at T1. This is where she's sitting and her head is starting to turn to the right. And then it evolves. So this is the evolution, and you can see this is evolved further. Even in evolution, it looks better on the left, though it also is evolving on the right. This is the termination with a attenuation at the end. So our hypothesis was correct. It was left temporal. The MRI of this patient was normal. I don't know if they have the MRI. So the PET I will show you. The PET shows this left temporal hypometabolism, and actually nuclear medicine felt there was a left parietal hypometabolism also here. So they reported the left parietal hypometabolism. In the PET MRI fusion, the basitemporal on the left was hypometabolic, and the basimesial was also hypometabolic, but this was a little more compared to the right, which is not hypometabolic. This was definitely hypometabolic on the left. We had done the functional MRI for language and memory, and you can see here that in the word generation task, which is for the motor speech, there is a shifting to the right. For the comprehension task, where jumble sentence task is given, yes, no task is given on a click button. Again, it had shifted to the right. And her memory was bilaterally represented. So though we were thinking of left temporal, the MRI was normal. Her fields were very interesting. She had a pie in the sky even before surgery. So she had a pie in the sky defect. This is a defect we see after surgery. But here, before the surgery itself, she had a pie in the sky, which gave us a clue that is, again, the left temporal, particularly because it is the right upper fields which were gone even before events. The MEG was left temporal, mesial, as you can see, and left posterior also, which is probably responsible for the pie in the sky. Dr. Jasmine here did the electrical source analysis of the spikes which she had. We take the very good spikes and again, this was again showing a left temporal dipole. The PASCOM, where we fuse one hemisphere PET to the other. So the PET is obtained and the right hemisphere is fused over the left. So the common or the noise cancels out and the uptake is by the area which is going to be the localizing area, and that was left temporal again. So everything was pointing to the left temporal, and with this, since left temporal is the dominant hemisphere and she's a young girl, she wanted to be a teacher. We decided, since the MRI was normal or declared to be normal, and she was discussed 7 times in our epilepsy surgery meeting. So the first patient was 5 times and the second patient was 7 times. Here, Dr. Aishwarya did her 5-sense score for her, and the 5-sense score was 57, and the cutoff is 37 point something. So obviously, a score of 57 means that she is a candidate for SEEG implantation even on the 5-sense score, and based on which the implantations were carried out.
So, as we see in the last case was completely cured as of now for a year with just RFTC ablation. In this case, we'll be seeing later. So basically the MRI didn't show any abnormality. As madam told, we discussed for 7 times. We didn't find any abnormality as such on the MRI, not because we didn't have the MRI to be shown here. But otherwise, rest of the investigations were mostly on the left side. So, but our main area of the anatomical localization is very important. Cases with MRI positivity have better outcomes, and then we always try to find a lesion on the imaging. If we don't, then we always, although we incline towards the rest of the investigations, but still there is a doubt that we cannot go ahead directly with the surgery because the anatomy is not very clear for us that it's an MR negative case. So we went ahead with mostly left-sided implants, left temporal standard implantation, as we did in the last I discussed in the last case. And on the right side, we just generally place one reference or the sentinel electrode for comparison. So here, as you can see that again, the amygdala, hippocampus on the left side. Left is left, right is right. So both anterior and posterior, we cover the temporal networks, including the head and the tail of the hippocampus with the amygdala, and also the lateral part with the anterior temporal lobe and the posterior temporal lobe. One electrode we had put on the basitemporal. Probably it will come somewhere. Sorry. Yeah, this one. So this electrode is the basitemporal, which we had put because again it was part of our evaluation, and I think PET also showed hypometabolism there. It is an interesting finding because once the resection part comes, we'll discuss. Meanwhile, I'll ask Madam.
So we recorded several events during the video EG. They were very similar. You can see her head and eyes turned to the right, followed by tonic posturing. So this part is in the neurosurgery ICU usually. On day 2, they move to the NS3 ward. So head goes to the right, comes back, then again goes to the right. So very similar to the, you have to see that the phase 2 events are similar to the phase 1 events. Okay, so again ictal onsets, you can see here, this is the LB. So this is left basi, okay, left basitemporal. Evolves in the left basitemporal, slow activity, further evolves, again picks up with spiking, picks up, And then she has generalized here. The hands have become tonic and it has spread everywhere. So those were the typical onsets. They were coming from this area. Okay. So in her case, again, stimulation was done, seizures were recorded, and ablation plan was done, and we ablated her. Following ablation, you want to tell about, I think this has come. Yeah, you can show that.
We don't have it. So coming, yeah, I actually, unfortunately, we don't have the pictures intra-op, but you can see the basitemporal one was the firing one, and while we were operating, when we lift the temporal lobe, we could see actually the encephalocele herniating through a defect, and actually it was an encephalocele indeed. And then when you go back on the imaging, because these are very rare, encephaloceles are very rare, and then you tend to miss on a MRI, and then this was, then in the retrospect we were wiser that it was a encephalocele, which is again a highly epileptogenic tissue, and then it was rapidly spreading to the other side. That's the reason on the EEG it was like bilateral onsets at the same time. So that was the main interesting point about this, was that because once we saw the encephalocele, we were like very happy that this patient will definitely have a cure, because you have seen it. And then she started having seizures. That's the reason we took her up for resective surgery. And then intraoperatively, when we found out, it was like a boon in disguise for the patient also. So here you can see, this is one study recently published. We had in our journal club discussed by our previous fellow Raghavendra. So they say that because encephalocele is one part of the brain which is herniating through defect, which is probably congenital dural defect, and then the tissue gets glyosed there and then it gets fixed. That's the reason it leads to tethering. So this is one of the indirect signs where you can actually say that this patient might have a encephalocele, that like this distance of the sylvian fissure at this level, it increases. And that part is more likely to have an encephalocele because of the tethering effect of the tissue. So gliosis is one of the major reasons of epilepsy, be it like encephalocele with a trauma, with a ischemia. So they can lead to epilepsy. So this was that interesting case. And then we have had around 6 encephaloceles till now, which we were lucky to spot.
I'll just finish by...
Yes.
So stereo EEG is a very useful investigation. It has to be done jointly with a hypothesis, based on a hypothesis with neurosurgeons as well as neurologists. And this is an upcoming publication by the International Federation of Clinical Neurophysiology, which talks about various stereo EEG terminologies. Okay. So I think the outcomes will be discussed by Dr. Sharath, or you are discussing?
So yeah, in the last case, we presented 2 cases. One where, the patient has forced thoughts. It's very, very fascinating. Would start the seizures with forced thoughts. MRI is absolutely normal. We put in a bunch of electrodes. We burned certain areas of the brain. Patient is doing well. So we don't actually know what the patient has. And there are recent studies to show that histopathologically it could be even normal. Most of this, there has been a recent paper where they have resected patient is seizure free, but histopathologically it was normal. In the second case, we found that we did an SEEG, patient was seizure free for some time, and then had started having seizures again, and we did surgery and we found a very beautiful encephalocele, and we resected the area around the encephalocele and patient was seizure free. So in the outcomes, this is our recent publication. This is the first series to be published from India. So we have shown, like in the first case, where only ablation was done, about 43.8% of our cases were seizure free with just SEG ablation. We didn't have to do any surgery. And considering the fact that these are patients, most of the MRIs of these patients were totally normal. And these patients have undergone repeated MRIs outside and they've been running from pillar to post. They have gone practically to all the institutions. They have done multiple MRIs, multiple anti-seizure medications. Many people said nothing can be done for these patients, and we were able to pick up a substrate. In a total of 62.1%, these of patients who following an SCG underwent surgery had good outcomes, which means whenever it is followed up with surgery, that is when the outcomes are definitely better. Now, in our series, we did say that 37.1% are MRI negative, which means absolutely nothing on MRI. You could not even see a bit of gliosis, bit of signal change or anything. And in about 53.8% of cases, we found that there were some changes. Again, these were very non-specific changes. Some white matter changes, some gray change, some gray matter, something like that. So, kaun sa hai ye? Yeah. So, of course, this is a team effort. So, I like to acknowledge all members of the team. And unless, this kind of cases, it requires a lot of effort. It's not like the usual neurosurgery. You see an MRI and then you operate. And of course, since we were getting a lot of tissues, we set up a very good research lab. We have a neurobiology research lab. We have a genomics research lab. So you could go and see the neurobiology research lab, which is on 7th floor of CNS and of the convergence block. Dr. Banerjee here is in charge of that. And we take out tissues and he measures the potentials from live tissues. So that's the reason it has to be put here so that the tissues reach within 15 minutes. And I would strongly advise all the residents to at least visit once. Because the paradoxical thing is you have everything here, but most of the residents don't end up knowing what is there. They move out of the institute, then they read some papers, and they think that, oh, this was there. So all the residents should visit this area. Now, before I close my, I'd like to show you that encephalocele because कैसे दिखाना है? कौन सा है? Where? ये क्या हो गया? Not responding आ गया. So let's show. No, it's okay. MRI is normal, okay? We have seen the MRI many times. It's totally normal. But of course, we picked up the encephalocele after the surgery. So this was done by Dr. Ramesh. So you can see when we were retracting the temporal lobe, that's where we found the encephalocele, and this is a remarkable finding. It could be a very small lesion, but it's remarkable from the patient's perspective, because once you find an encephalocele, that means you do a resection of encephalocele and the area around it, of course with electrocorticographic guidance, and you can be almost sure that 80% of the cases this patient is going to be seizure free. And you have to understand that this seizure patient was having seizures for many decades, multiple seizures, and they lose everything because of the seizures. So histopathology was gliosis. So with that, we will stop our grand rounds. We are right on the time. So any questions or any kind of comments, any questions from the residents here? Anything, Deepak, anything you want to say on them? Well, this was MRI negative. Yeah, in a way, retrospectively it becomes MRI positive. But then I will show you the slices of the MRI. In the highly magnified views, you see something going inside, which you will never think of, you'll never imagine thinking that there will be some problem here. Now the danger of saying that it's MRI positive is it will make people forget what all efforts actually went through it. And this was more like a retrospective diagnosis. If you went through the whole path and then you say. So I would say that, in a way, it's a microencephalocele. It was made evident by an SCG, and we found something good there. We found a definite substrate and we resected it. So retrospectively it does become MRI positive. But if you look at the images, I can show you the images. And all these images were 1 millimeter sections, harness protocol, every kind of protocol was followed and nothing was seen and was discussed ad nauseum in the epilepsy. The radiologists were fed up. They said there is nothing here. The bony defect, it's a very microscopic defect. Even if you miss it, you will not see it. That's a problem. We have done a resection, so we called it encephalocele, but most of the post resections, post ECG resections, we feel as if we are resecting normal tissue. Histopathology, it comes as cortical dysplasia, we are a bit happy. Yes, so we picked it up because we knew something was there. So everything was pointing to left temporal, and Dr. Manjari was saying, "Bhaiya, wahan pe kuch hai, dekho. Operation or kuch bhi hai." So we had a high index of suspicion when we were exploring there. And one of the etiologies for a MR negative left temporal etiology is an encephalocele. You could get a cortical dysplasia, you could get some kind of and encephalocele is something you have to look out. So that's the reason you always have to lift up the temporal lobe and see if there is an encephalocele or not. Even you have to go to the front and then pull the pole apart to see it's not sticking anywhere. See, these are very subtle pathologies. These are very unusual pathologies that normally we don't speak in the neurosurgical fraternity. And these are spaces which nobody has explored. And these are the patients who continue having seizures day in and day out for months together. And we don't explore because somewhere we have thought nothing can be done for this group of patients. But now we are kind of opening the Pandora's box. Now we are realizing, networks may not be histopathologically abnormal. They could even be histopathologically normal. So it's very important to now start localizing the networks. Yes, Satish? Yes. So that again, many times an encephalocele can be a red herring. You could have asymptomatic encephaloceles. But in this case, we have investigated. So that particular encephalocele definitely symptomatic. The other thing which gave us a hint that this encephalocele is responsible is the preoperative pie in the sky defect, which means there is a definite traction there. And as per the Cleveland publication, you see this is a widening of the fissure. So when we look at the frontotemporal aperture, we definitely found that this fissure was again widened. So these are some kind of a subtle hints to show that this encephalocele definitely. I agree that some group of patients could be having encephalocele which is asymptomatic throughout the life, but only some encephalocele, they become symptomatic, like an NCC. Some people may have asymptomatic NCC, never have seizures, but some groups of NCC, they become symptomatic. But now, we have the background we have the strength of all the investigations done. So we definitely know that there should be something. So that's how it becomes very significant. Yeah, so when we put the electrocorticography, that whole thing was abnormal. So when we do SCEG, it's not that we use electrocorticography to tailor the final resection in that area. See, one has to understand this, especially the residents. When you put in an SCG electrode, which is size of 0.8 millimeter, it sits around 1 million neurons. Okay, and each neuron is connected to 10,000 neurons, which means you could place 10,000 SCG electrodes, you will not find the focus. So that is why Aprajita was saying you cannot go on a fishing expedition. So you need to do very good preoperative investigations. You need to have a very strong hypothesis. And in our program, what we do is we need to minimize the number of electrodes, because these electrodes are of course given free of cost. But we need to minimize because these electrodes are expensive and we reuse electrodes. So in our program, we always make it a point that we do not create a hypothesis. We always try to prove a hypothesis. So by the time our investigations are done, we almost know where it is. So this is the area where it is. And we put electrodes and that confirms that this indeed is the area. Okay, so we will end this. Thank you.